Hello students, welcome to the EPG Pathshala. I am Asha Banu, faculty with the Center for Health and Mental Health, School of Social Work, Tata Institute of Social Sciences. Right now we are going to look at a module called Social Perspectives in Mental Health. Just two objectives. One, to understand and appreciate diverse theoretical perspectives contributing to mental health by sociologists. The second objective is to reflect and understand how social, cultural and political factors influence mental health. Now, why social perspectives? Oftentimes we work with a psychiatric understanding and we have a biomedical approach, and we also keep talking about biopsychosocial approach. And now why particularly we have to learn about social perspectives? It is not just to play a psychosocial intervention as part of the multidisciplinary team, not just for the purpose of provision of services, but developing frameworks by which to make sense of mental distress and actively devising strategies for promoting recovery and positive mental health. This is the need of the hour, and as social workers we have to be very creative and innovative in evolving strategies to promote recovery as well as positive mental health in the larger society. The second reason why we have to understand social perspective is to commit ourselves to a holistic approach. And third important reason is to seek an understanding that is holistic and integrated, to evolve an integrated understanding of people in their social context rather than just focusing on either one or inner or outer aspects of an experience in isolation. So far we are familiar with the dominant paradigm, the biomedical paradigm, and whenever we talk about mental health, it is always synonymous to psychiatry. The definitions by WHO is talking something about a holistic well-being, but then even in today's context, when we talk about mental health, immediately a common perception or a common man's perception is it is equated to psychiatry or a psychiatrist. So the dominant view, psychiatry or the medical model, views mental health illness as an intrapsychic phenomena. Until recently, the dominant perspective that governs the field of mental health is the biomedical model. And mental health experts through their experience have realized the relevance of psychosocial rehabilitation. However, social, cultural and economic factors receive less attention compared to biological explanations and interventions. This actually we can see in hospitals, outpatient departments, government hospital psychiatric units. What happens is the patient visits, the role of a social worker is very limited, either in terms of providing a referral service or getting a economic resource for the person who is coming, rather than focusing on a holistic intervention designed for the client. Mental health services are generally organized within hospitals and institutions where the majority of helping professionals are psychiatrists and clinically oriented paraprofessionals. So far this is what we see. We see a hospital, we see a GHPU. These are the contexts for mental health interventions, and that's why till today the dominant paradigm is being a biomedical paradigm. Now, it is really time for the social workers to look mental health through a different lens, drawing from whatever definitions that the international organizations are providing. Desai 2003 states that when it comes to intervention, social workers commonly feel overwhelmed and debilitated by medical practitioners who claim much more expertise on mental health issues. Social workers in these settings are likely to be more interested than their non-social work colleagues in the social and environmental factors related to mental health, but one could contend that the basis of care in mental health organizations as well as the interventions and the organizational structures typically emanate from a medical model. So, the creativity or the practice skills the social workers gain from the practice domain gets compromised while working in a mental health institution, because it is devised and designed for a particular purpose, that is treatment and treatment using a biomedical model. So when we go to a hospital, it is already structured and the psychiatrist will have a say in terms of what are the psychosocial interventions the social worker can do with a particular client, and the structure that would be already available would be a vocational unit or occupational therapy, but then it won't be in terms of the indicators that we want to use in terms of emancipatory practice with the clients. So oftentimes we feel very restricted within a particular environment to use all the practice skills that we have learned through the social work methods. Medical terminology is used in hospitals, mental illness, mental disorder, diagnosis and patients, and often it is it's like the social workers try to understand mental illness, but then there is no active role in terms of what can be done vis-a-vis a illness. Medically oriented diagnostic and assessment processes are employed. Organizations are structured such that medical disciplines maintain power over other disciplines and consumers. So when we are designing an intervention, that also would be under the guidance of a medical practitioner or a psychiatrist. So as I initially mentioned, it's lot of restriction and there is lot of scope for the social work practitioners to engage in a much more holistic manner and to be focusing on larger issues of stigma, social exclusion and social justice. The domination of biomedical approaches to mental health has so far offered very little space for the articulation of diverse perspectives, and diverse community-based models that works with an understanding of the social underpinnings have proved to be effective, and thus it is time for the social work practitioners to get a grip on the sociological underpinnings to mental health. In the Indian context, we have some of the leading organizations which really is rooted on the social underpinnings, which works on the principles of equity and justice, and they are proved to be much more effective. And also it promotes positive mental health in the larger community, as well as it's also promoting recovery and resilience of persons with mental illness. Thus, this module is an attempt to help the social work students to understand mental distress from a social perspective. Yes, it is also important to understand the biomedical model. It is also important to engage ourselves in clinical practice, but at the same time it is also important to evolve a new lens to understand sociological perspectives. Now, when we are talking about sociological perspectives, it is not new names. We would have already read in critical perspectives course that has been offered to you in your classrooms or through the EPG Pathshala. So the names are going to be much more familiar. One is Durkheim, Weber, Foucault and Marx. Not going to go on into detail of their contributions, but how it can be connected to view mental health and mental illness. The social cause of mental illness is attributed to disadvantaged social status and stress. Social stress theory and its relevance have been discussed in the 1980s and continue to guide many sociological studies. The understanding is that mental disorder is not equally dispersed throughout society, but occurs more often within socially disadvantaged groups. This theory emphasizes that mental health problems are caused by exposure to social stress. Later we will see the social causation and social selection in one of the later slides, based on social statuses and earlier life experiences, as well as vulnerability to stress, a limited ability to cope because of low levels of social support, self-esteem or mastery. In fact, in one of the courses, the continuum would have been discussed. How mental health and mental illness should be viewed as a continuum, and if a person do not have the social support mechanisms, the person would be drifted so easily towards mental illness. So it's also it's drawn from the social stress theory that the more support mechanisms, the more privileges a person has, the lesser he moves towards mental illness. Now, the first and foremost which we would see is Durkheim, and many of you would have read his contribution on suicides. Suicide may be caused by weak social bonds, and social bond is a result of social integration and social regulation. For whatever reason, the social integration and social regulation goes for a toss. Now, Durkheim has given has seen suicides into 4 categories. One is egoistic suicide, where individual is weakly integrated into a society, so ending their life will have little impact on the rest of the society. The second he classifies as the altruistic suicide. Individual is extremely attached to the society and because of this has no life of their own. The anomy suicide, there is a weak social regulation between society's norms and the individual and is most often brought on by dramatic economic or social changes. The fourth comes the fatalistic suicide. Social regulation is completely instilled in the individual. There is no hope of change against the oppressive discipline of the society. Feels that the only way to escape this state is suicide. So in the next slide, we will see farmer's suicide through the Durkheim's lens. 2 broad types of causes of farmer suicides. The first one is the disappointment and despair that resulted from the disproportion between achievements and aspirations conditioned by rapid economic growth and the spread of neoliberalism. The second is the isolation that emanated from weak ties with the family, neighborhood and community following individualization of agriculture and decline of the traditional social order. Initially there was a traditional social order and a social regulation that has gone for a toss. So while the former results from loss of social regulation, that is anomy, the latter indicates loss of integration, that is egoism. The second sociologist in the contribution most of us are familiar with is Marx, and there are lots of readings on Marx and mental illness or viewing mental health through a Marxian lens. So we will just see a glimpse of how we can connect conflict theory to mental health. In his Communist Manifesto, Marx argued that the history of humanity is the history of class struggle. And this struggle is between the oppressors and the oppressed. For social workers, this is a familiar terrain, and constantly we keep talking about the power struggles in the larger society. The oppressors are the class of the bourgeois and the oppressed, the proletariats, are members of the working class. The bourgeois owns the means of production and consequently is economically, politically and socially advantaged compared to the proletariat. The differential level of status between the bourgeois and the proletariat has been used by sociologists to explain the high prevalence of rate of mental illness among individuals with low socio-economic status compared to those with higher socio-economic status. Gender difference in mental health is another area in which the conflict theory is applied. The conflict theory informs why women experience higher levels of mental health problems compared to their male counterparts. How violence is being normalized because the male has the position of power to violate the rights of a woman, and so there are, when the dissent when there is a dissent from the women's side, that is not considered as being normal. Now, in his literature, Bruce Cohen on psychiatric hegemony, he has documented how dissent was pathologized, the normalization of conditions of slavery, the psychiatric incarceration of political activists, the labeling and drugging of young people with school-related disorders, the lobotomizing of problematic vice. Just in the previous slide I said that violence is considered very normal, and social learning theory is often used as a theory to the understanding of violence. Social learning is one of the theories that contribute to the understanding of violence. So violence against women particularly is considered very normal, and the dissent from the part of the women will always be considered as abnormal and would be hospitalized, and men have the privileged position in the society to incarcerate women, because often when a person is labeled with illness, the person loses the capacity to talk about their own mind and well-being. Now, as a social construct, according to Sass, schizophrenia is a social construct. a label for the sort of thinking and behavior that society finds undesirable. Sarce's point is very similar to Foucault, one of the forerunners of the anti-psychiatry movement. According to Foucault, madness is a social construct dating back to the Enlightenment, and its treatment is nothing more than a disguised form of punishment for deviating from social norms. We have enough documents to read on that. You also can read narratives from people who have been incarcerated. It's all important for us to understand and position ourselves where we want to position. This particular module definitely gives you the opportunity to understand the wide range of perspectives and locate yourself where you want to locate as a mental health social worker. Labeling behaviors as being indicative of mental illness was a political decision rather than a scientific determination, and that treating an individual through institutionalization and medication was a method of deviance control. This is also emerging because lots of people who are part of the anti-psychiatry movement or the users movement raise concerns about the objectivity in the diagnosis of mental illness, and so far we have not been able to prove the objectivity. There are narratives which says that the same person demonstrating the same set of symptoms have been diagnosed with different labels in different psychiatric facilities. So that's the reason it says it's a political decision rather than a scientific determination, because in time periods when conformity was encouraged, minor deviations from the norm were punished through the application of labels such as mental illness. The client becomes a schizophrenic and not a person who suffers from this disorder. So we take the human from the person. And as social workers, we also see how a mother would be separated from the child on account of mental illness. The mother do not have a choice. She does not have a say in keeping the child with her because of that particular label, because she becomes schizophrenic. Now, learning from these sociologists, these are also two hypotheses that has been worked by contradicting hypothesis, but has been attempted by various sociologists, but both says that lower economic strata there is a higher concentration of mental illness, but both these hypotheses contradict each other. One is social causation, one is social selection. It is important to understand both these hypotheses. Because most consistent finding across studies is that lower socioeconomic groups have greater amount of mental illness. What does the social selection hypothesis say? It says lower class position is a consequence of mental illness. They say that because there is a genetic predisposition, the person is ill, and because of the illness, the family is drifting towards the lower socio-economic strata, and that's how we see a higher concentration of people in the lower socio-economic strata with mental illness. So this is also important for us to understand when we are working with the rights perspective. That means we are taking about the, we are discriminating the person with mental illness. There is no support system for the persons with mental illness. The person is not able to go for a job. There is no understanding of mental illness in the larger society. There is no easy referral mechanisms and early intervention that is available for the mental illness. That's why the drift becomes possible. So even using this hypothesis, when we see if a person is really drifting towards a lower socioeconomic strata because of an illness, this is easily considered, this can be easily construed as injustice against persons with mental illness. So the interventions for persons with mental illness should be garnering support and work on this towards creating a equitable society. Next comes the social causation, which is contradicting the social selection, wherein it says the lower class position is a cause of mental illness. So here it says social stress causes mental illness and lower income people experience more social stress. This can be drawn from multiple other sociological perspectives which we have studied. So both these perspectives conclude that the people who are most affected, and why concentrations of mental illness is amongst a particular group of people in the lower economic strata. So this particular lens of the marginalized society is very important. Either it's a resultant of illness, or is it because of or is it caused because of lower economic strata. It is important for social work students to draw from their discipline to work keeping this understanding in mind, and that's how the rights approach becomes very critical. Now moving towards social model of disability, this can be a response to this can be a understanding which can contribute to work on the sociological underpinnings. The social model of disability says that disability is caused by the way society is organized rather than by a person's impairment or difference. The social model of disability identifies systemic barriers, stereotypes, stigma and exclusion by society, thus disabling people. The model demands ways of removing barriers that restrict life choices for disabled people. Now for example, I work in the field of aging. Often I find that people consider aging as a curse because their mobility is restricted. Why mobility is restricted? I never had a response till I went to a different place where they called it as a age friendly society. People can move, people can take cabs, people can take the public transportation. The mobility is not a concern, but in the Indian context that's not a possibility. So this defines that the systemic barriers results in disabling one set of population. They get arrested to their own space because they cannot access public transportation in a crowded facility. So this is how we have to understand. It is not the disability which is restricting the population, it is the systemic barrier, the stereotypical way of thinking about disabled people, the stigma and the social exclusion the society has caused against certain set of people. The model demands ways of removing barriers that restrict life choices for disabled people. Thus, the social model of disability focuses on changes required in society. First and foremost, we have to work in terms of change of attitudes. There are lots of misconception notions even about disability. Often disability and mental illness is considered as a curse. So change of attitudes in the larger society is very important, and particularly with mental illness the notion has to change because there is range like starting from distress to severe mental illness, and the disability is not the same, the level of disability is not the same, and it's really important to change the attitudes of people on and create an understanding of what mental illness is, and lots of campaigns have to come on this. The second is how to work in terms of inclusion. How to now we often hear about inclusive education, how persons with disability can be roped into the normal schools. Our institute is the best example to how the university has changed itself, how the university has done an access audit and made the campus or attempted to make the campus as a disabled friendly campus. So how in what ways diverse contexts can become inclusive, right from a shopping space to the public transportation to university spaces to school spaces, how in all the places the structures can change to include persons with disability and mental illness, creating policies, workplace policies, school based policies, university level policies, and how inclusion can be enhanced. Third is in terms of information and choice. When it comes to mental illness, there is nothing like a choice. So I have to listen to my caregiver, I have to listen to my family. It can be both intimidating or it can be patronizing, but then as a person with mental illness, the choice is not given to the person with mental illness. So insight is important for the individual about the illness, the information has to be provided, the range of options available for persons with mental illness should be given, and the choice should not be taken away. Because a person has mental illness, the person should not be curbed from going to a higher university. Because a person has trauma episodes and anxiety related disorders, she should not be curbed from traveling on exchange. So you can cite multiple examples how people are people are stopped from doing what they want to do because of their illness. We have to work towards creating a just society for everyone. Next comes infrastructure. In the context of disability, that was a huge transformation, how infrastructure should become disabled friendly. Then comes support. So how creative, how constructive, what are the kind of support mechanisms we have to put in place is very critical. So now starting from the first slide, we tried understanding there is multiple other perspectives that contributes to the mental health discipline, and it's important to appreciate and understand all these theoretical underpinnings. Here it was just a glimpse, but as social work practitioners, we learn the same theories, and how we draw from those theories to understand mental health becomes very critical. Then different contributions from different sociologists is important for us to see, and look at social causation, social selection, how both hypotheses say that the concentration of persons with mental illness is amongst the lower socio-economic strata, and how we work towards creating a social model of drawing from social model of disability, how would we work on strategies at our own levels. And now I would just conclude by stating some of the value-based underpinnings for social work practice in mental health. The first and foremost, social perspectives must embrace diversity. There is a need for a plurality of overlapping perspectives that reflect the complexity and diversity of experience based on a range of factors such as gender, culture, economic status, age, personal biography, and family and social relationships. So it's important to embrace this diversity, not look at an illness like an illness. But again, that illness is an experience, and the experience is rooted in the identities. Social perspectives approach requires an end to them and us thinking that imposes splits between normal people and those suffering distress. This is important. Like if according to WHO, if it is 1 in 4 will suffer mental illness at any given point in time, there can never be a them and us. There can always be a I in the them. So it's important to understand it should not be like I am a so-called normal person and the person is abnormal. It should not be the them and the us. So it's important that mental distress should be seen as situated within a continuum of everyday lived experience and not constructed as some alien entity which separates out some people as fundamentally different and starts to define their identities in terms of their pathology. Social perspectives approach demands a holistic approach, always seeking an integrated understanding of people in their social context rather than just focusing on either the inner or the outer aspects of their experience. As part of this, there must be a willingness to engage honestly with all the fractured and contradictory elements that may constitute a person's experience and social relationships. Social perspectives approach may be seen as explicitly emancipatory in its purpose, aiming to support a practice of working together that enables people to recover a meaningful degree of control over their lives, live in greater safety, and participate more fully within social, economic, and community life. Social perspectives should be informed by principles of anti-oppressive and empowering practice. This involves an awareness of power differentials and maintains a concern with those factors which may diminish people's sense of self-esteem or value or constrain their personal, social, and economic opportunities. It places questions of stigma, discrimination, inequality, and internalized oppression firmly on the working agenda. So this is these underpinnings have been taken from a book which you have to read, which is Social Perspectives in Mental Health, which is given as part of their references as part of the module. Now, what is important here is look at the Indian context. Look at the scarcity of resources, look at the lack of innovations, except fewer organizations that can be hand counted in the Indian context. So there is lot of scope for the social workers to really innovate models in the field of mental health. Do not depend on one paradigm, but draw from multiple paradigms, and let's see how we can mainstream mental health work. Even when we are working as part of the livelihood projects, even when we are working in a larger community project on development agenda, let's take mental health as one agenda, as part of the development agenda. It's very critical. There is so much of a scope for you to work in the mental health sector. Concluding, social work education is informed by critical perspectives and aims to challenge oppression and poverty and arrest structural inequality. So the same should be the true in the mental health context. Thus, it is appropriate for the mental health social workers to use the lens of critical perspectives in understanding mental health concerns and challenging oppression. So let's move beyond the biomedical model. Let's draw from our professional discipline, from the strengths of the critical perspectives that we learn from the other program, and create more and more just and equitable society for all. Thank you.